What are the risk factors for transition from acute low back pain to chronic low back pain? Historically, it's been assumed that acute low back pain resolves in most people within 3 months, but the ranges in the literature vary due to probably a heterogeneous population and different definitions of what chronic low back pain is. A systematic review indicated that 2 to 48% of patients with acute low back pain transition to chronic low back pain, but in another study of primary care patients with acute low back pain, the range was 9 to 35%, but that was at 6 months. A new study evaluates not only the percentage of acute low back pain patients who transition to chronic low back pain, but also potential risks for that transition based on some initial indicators and then the type of management that's followed. This study was published in JAMA Open in 2021 called Risk Factors Associated with Transition from Acute to Chronic Low Back Pain in U.S. Patients Seeking Primary Care. So specifically, the questions that were asked were, what percentage of acute low back pain patients transition? Are there factors that affect transition from acute to chronic? Does the adherence to guideline recommendations for the management of acute low back pain influence whether patients transition to chronic low back pain? And are there comorbidities that influence transition, and are they modifiable? Can these factors be screened for by placing patients in categories of risk that then predict transition? And can these be used to triage patients when they present with acute low back pain? So let's look at current guideline recommendations. Non-pharmacological interventions such as heat, massage, acupuncture, or spinal manipulation are recommended as first-line treatment options. Initial use of diagnostic imaging, specialty consultation, and prescription of opioid medications in the absence of red flags are not recommended. In the present study, the variables that were evaluated for the transition of acute to chronic low back pain were compared with baseline SBT risk strata. That stands for the Start Back tool, which we'll look at in a second. Patient demographic and clinical characteristics and practice characteristics, and guideline-based non-concordant processes of care. We'll discuss that in a second also. But first, how is chronic low back pain defined? Their classification criteria were that acute low back pain was less than 1 month or 1 to 3 months, or more than 3 months and less than half the days. Chronic was categorized as more than 3 months and half the days or more than half the days. The researchers focused on categorization of risk based on a screening tool first reported in this study, a primary care back pain screening tool identifying patient subgroups for initial treatment. The intention was to screen individuals for psychological indicators that might be remediated from the onset of care. In this study, the psychological intervention was provided by trained physiotherapists. The name of this questionnaire was the Start Back Screening Tool. Let's look at the questionnaire. Item 1 is overall, how bothersome has your back pain been in the last 2 weeks? And then there are 8 more questions for a total of 9. Hidden within these 8 questions are psychosocial subscale items. So this includes item 1 and item 4, 7, 8, and 9. Number 4, it's really not safe for a person with a condition like mine to be physically active. Number 7, worrying thoughts have been going through my mind a lot of the time over the last 2 weeks. 8, I feel that my back pain is terrible and that it is never going to get any better. And number 9, in general, in the last 2 weeks, I've not enjoyed all the things I used to enjoy. The questions are screening for behaviors like fear avoidance or catastrophizing, as well as depression. Fear avoidance means avoiding pain because the patient believes it's damaging. Feeling like there's no hope of returning to normal life would be an example of catastrophizing, and lack of enjoyment in life, or anhedonia, is a screen for depression. An answer yes to anhedonia might prompt the use of more specific screens, such as the Patient Health Questionnaire 9, and if the score reaches a threshold of 10 or greater, it prompts psychological referral. The risk categories were an overall score of 3 or less is a low-risk group. An overall score of 4 or greater or a subscore of 3 or less is considered a medium risk group. And for the high-risk group, it's a total score and a psychosocial subscore of 4 or greater. This was a fairly complex protocol design. Patients who were identified at baseline as having low and medium risk were only included in the observational component of this study. Patients screened as high risk were included in the observational, but also included in a cluster randomized trial component of this study. In the clustered randomized trial, patients received either usual care or the intervention, which is usual care with psychologically informed physical therapy, depending on the clinic where they presented. The researchers also classified patients based on disability using the Oswestry Disability Index. So what is non-concordant care? This is care not recommended by guidelines and includes basically 3 components: medical referral, pharmacologic, and imaging. In medical referral, this would include referral to physiatrists, orthopedists, neurologists or neurosurgeons, or a pain specialist. Pharmacologic non-concordant care would be the use or prescription of opioids and benzodiazepines or systemic corticosteroids alone without the use first of nonsteroidal anti-inflammatories or short-term skeletal muscle relaxants. And imaging would include lumbar radiographs, MRI, or CT. Now on to the results. The acute to chronic low back pain transition rate at 6 months was 32%. The odds for transitioning were higher for those with higher baseline disability, low back and leg pain, obesity, smoking, psychological comorbidities, and having insurance. And based on risk groups and chronic low back pain transition, 60% of patients who developed chronic low back pain at 6 months were in the low risk and medium risk groups. The rate of transition is lower, but most patients with acute low back pain, 75%, fall into these 2 groups. We can see here the percentage of non-concordant care. For example, 30% were prescribed medication, 24% received imaging, and 6% were referred to specialty care. The comparison between concordant and non-concordant care is illustrated in this graph. For example, with pharmacologic treatment, those receiving prescription, 39% progressed to chronic low back pain compared to 29% who did not receive prescription. 36% who received imaging progressed to chronic low back pain versus 31% who didn't. 53% who were referred to specialists progressed to chronic low back pain compared to 30% who didn't. And 53% of patients who received 3 or more non-concordant approaches progressed to chronic low back pain compared to only 27% who had 0 non-concordant management indicators. The researchers conclude that the StartBack screening tool was a robust prognostic tool and, quote, early exposure to Guideline non-concordant care was significantly and independently associated with the transition to chronic low back pain after accounting for patient demographic and clinical characteristics such as obesity, smoking, baseline disability, and psychological comorbidities, unquote. Quote, these findings suggest that an emphasis should be placed on discovering strategies to successfully implement Guideline concordant care in the primary care setting to reduce the development of chronic low back pain, unquote. So how does this affect the average chiropractic practitioner? The first is to understand that acute low back pain transitions to chronic low back pain are more often than once predicted, and there might be several ways to decrease that transition. Attempt to intervene on the modifiable risk factors specifically for smoking and obesity. Either recommendations or referral may be helpful. Avoid non-concordant approaches such as early imaging, and screen for psychological components in acute low back pain patients such as fear avoidance, catastrophizing, or depression using the StartBack tool or specific questionnaires for each, and dependent on which, refer for psychological consultation or seek training in early interventional approaches.